Good morning or good afternoon, good day, wherever you are. Welcome to today's webinar for the AC Forum, and we're excited to talk about this topic. We're going to be discussing today emerging evidence, long-term oral anticoagulation following provoked VTE, a focus on the HiPro trial. I was super excited to see this trial come across, and we kind of immediately, with rather short notice, reached out to the lead author who was kind enough to join us today to discuss this trial. Next slide. I'm joined today by my co-moderator, Naomi Yates, from Kaiser Permanente Anticoagulation Service, a clinical pharmacist. I myself am a clinical pharmacist, anticoagulation program manager at the VA hospital in Salt Lake City. Our presenter today and the lead author of this trial is the man, the myth, the legend, Greg Piazza, director of vascular medicine at Brigham and Women's Hospital and associate professor of medicine at the Harvard Medical School. And we're joined also today by a panelist and newest member of the AC Forum webinar committee, Margaret Fang. She's the chief of the Division of Hospital Medicine at the University of California, San Francisco. Next slide. A couple of quick announcements before we let Greg have the mic. Next slide. So just as a reminder, we have coming up here in about 10 days, the Anticoagulation Forum boot camp. Registration is still available. So have lots of insights from industry experts, as opportunity to earn CE, some chalk talks that are always a favorite of these webinars, or excuse me, these boot camps. So I definitely recommend registering for that. Next slide. And again, relatively new to the AC Forum is AC University. If you want more formalized kind of training opportunity to access other content that sits behind a paywall, AC University is the way to go. We still have some premium education from the 2025 conference. We have also the virtual boot camp content, some on-demand stuff, as well as a CARE AF and VTE learning series. Highly recommend. Next slide. And at this point, I'm going to kick it over to Greg to teach us all about this HiPro study. Take it away, Greg. Thank you.
Thanks so much, Arthur. And it's a delight to be able to join everyone today and my colleagues from AC Forum. I'll be going through the context, a bit about the HiPro trial, and a little bit unpacking the questions that remain after the study. So really looking forward to this. Here are my disclosures. The study was funded by a research grant from BMS Pfizer. And for so many decades now, we have divided VTE into provoked and unprovoked for the purpose of determining risk of recurrence, but also optimal duration of anticoagulation. And yet the field has really started to ask more of us in understanding patients' risk. Unprovoked and provoked as a dichotomous way of determining duration of anticoagulation had direct implications in that provoked venous thromboembolism was typically or has been treated with anticoagulation for about 3 months, and then oftentimes these patients were felt to be low enough risk to discontinue. And unprovoked venous thromboembolism or idiopathic venous thromboembolism was felt to have a high risk of recurrence, such that anticoagulation was continued long term. But more recent epidemiological cohort studies have suggested that patients with persistent venous thromboembolic risk factors, even if the initial circumstance occurred with a provoking factor, have a high risk of recurrence. And I'll note that the words provoked and unprovoked, even though the field is not using that necessarily to dichotomize patients, still finds its way into our guidelines. The ISTH guidelines have emphasize the importance of recognizing major and minor provoking factors, as well as major and minor persistent provoking factors, rather than simply using the terms provoked and unprovoked to understand the patient's risk of recurrence. And so this more granular way of looking at risk made its way into the 2019 European Society of Cardiology guidelines, where there's greater emphasis placed on these nuances. Low-risk patients are thought to have a less than 3% risk per year. This typically includes patients with major transient or reversible factors, provoking factors, including surgery, including major prolonged immobility, or trauma with fractures. On the other end of the spectrum, the high-risk patients have a greater than 8% risk of recurrence per year, and this is comprised generally of patients that have active cancer, have had recurrent venous thromboembolic events in particular, oftentimes unprovoked or in the absence of provoking factors, and then patients with significant thrombophilia. In the middle, we have the yellow zone, which we call intermediate. These patients have a 3 to 8% risk per year of recurrence, and really includes a broad selection of risk factors, transient provoking factors, including minor surgery, hormonal therapies, pregnancy, more minor orthopedic injury, travels included there. And also patients that have important persistent risk factors. Two called out in this figure here include inflammatory bowel disease and other autoimmune disease, but also you'll find that no identifiable risk factor also reaches the bottom of this yellow zone. Unfortunately, because these groups are very heterogeneous, it's hard to provide much guidance for duration of anticoagulation, and patients who present with venous thromboembolism in the setting of a provoking circumstance who might have enduring risk factors haven't had a firm recommendation for what to do with their anticoagulation, and many clinicians were left to decide what to do on their own. So that was really the impetus for the HiPro trial. We received so many of these referrals to our vascular medicine clinic at Brigham and Women's Hospital that it seemed appropriate for us to try to answer this question. And we hypothesized that extended duration thromboprophylaxis with apixaban 2.5 milligrams orally twice daily would be able to reduce the incidence of symptomatic recurrent venous thromboembolism and wouldn't increase the incidence of major bleeding. We can see the overall study design here. We focused on patients who had acute provoked venous thromboembolism who were treated for at least 3 months. The patients had to have at least one enduring factor. They were to apixaban 2.5 milligrams daily for 12 months or a matched placebo. I'm not going to go through all of the details of the inclusion and exclusion criteria. Suffice to say, we were focused on adults with objectively confirmed DVT and/or PE treated for at least 3 months. The risk factors for VTE recurrence that we considered included obesity, heart failure, chronic lung disease, chronic kidney disease, inflammatory diseases, and atherosclerotic cardiovascular disease. Some patients have multiple risk factors, and then in general, we exclude patients with cancer and patients that either had a strong indication to remain on anticoagulation or a high risk of bleeding such that it wouldn't really make sense to have them on long-term anticoagulation. We look at our efficacy and safety outcomes. This was over a 12-month horizon. Our primary efficacy outcome was the time to first symptomatic, recurrent, objectively confirmed venous thromboembolic event, defined as a composite of DVT and/or PE. Our secondary efficacy outcome was time to first occurrence of a composite of death due to cardiovascular causes, non-fatal MI, stroke, TIA, or systemic embolism, major adverse limb events, or coronary or peripheral ischemia requiring revascularization. Our principal safety outcome, time to first occurrence of major bleeding according to the ISTH definition, and our secondary safety outcome was the time first occurrence of ISTH clinically relevant non-major bleeding. For our primary efficacy outcome rate, we assumed a 6% incidence in the placebo arm and a 75% relative risk reduction with apixaban for a two-sided alpha of 0.05. To detect a difference of the primary efficacy outcome between study groups, each arm was estimated to need 279 patients for 80% power. And assuming 7% dropout, we settled on a total sample size of 600 patients with 300 per arm. Our primary efficacy analysis was based on time from randomization to first occurrence of any component of the primary outcome, up to and including day 365, and this was done by intention to treat. Our principal and secondary safety outcome analyses were performed on a safety analysis set, which was defined as subjects taking at least one dose of assigned treatment and included the time interval from that first dose all the way to 96 hours after the last dose. Here we can see our study flow. We evaluated 1,195 patients for eligibility. 209 patients declined and 386 did not meet the eligibility criteria, leaving 600 patients who underwent randomization. 300 in the apixaban arm, 300 in the placebo arm, and those comprised our intention to treat analysis sets. 6 patients in each of the arms did not take any doses of the assigned medication, and that left 294 patients in the apixaban arm and 294 in the placebo arm that were ultimately comprising the safety cohort and the modified intention to treat cohort. And so here we can see results from the HiPro trial. These are our baseline characteristics. This population fits very closely with what we expect at our center for venous thromboembolism patients, a mean age of about 60 years. We were happy to get almost 60% female. We had almost 20% non-white, which I think is nice to see. And body mass index was about 31 kilograms per meter squared. And about 20% of patients continued low-dose aspirin during the study period, and that was limited to 81 milligrams of aspirin per day or less. We can see the information for the baseline characteristics of the apixaban and placebo group, and by and large, there was reasonable balance in these characteristics across the groups. Looking at qualifying initial venous thromboembolic events, there was a bit of a predominance for isolated CAF DVT in the placebo group and a bit of a predominance for pulmonary embolism in the apixaban group. And you can see that a reasonable percentage of patients had both PE and DVT. Looking at overall venous thromboembolism risk factors, both the provoking factors as well as enduring factors. For provoking factors, commonly and as expected, we saw quite a few patients with surgery, trauma, infection, immobility. And then for enduring risk factors, the common issues that came up were obesity, chronic lung disease, chronic inflammatory disease, and atherosclerotic cardiovascular disease. And once again, between the apixaban and placebo arms, there was reasonable balance in these risk factors. And so now we get to the primary efficacy outcome analysis for symptomatic recurrent VTE. What you see in blue is the cumulative incidence of symptomatic recurrent VTE in patients who were assigned to the placebo arm by intention to treat. And we noted that in patients assigned to apixaban 2.5 milligrams twice daily, there was an 87% relative risk reduction in the endpoint of symptomatic recurrent VTE. We did not observe any significant difference in major bleeding by ISTH definition, and the overall rates were very low. There was a numerical increase in clinically relevant non-major bleeding that did not reach statistical significance in the apixaban 2.5 milligrams twice daily group. Looking overall at our clinical outcomes, just a few things to point out. No patients assigned to apixaban 2.5 milligrams twice daily suffered pulmonary embolism. And the one major bleeding event that was noted in the apixaban group was a 3 millimeter parafalcine subdural hematoma that occurred in a patient who fell from a horse. This didn't require hospitalization, and after consultation with neurosurgery, didn't even require discontinuation of the study drug, and the patient has had no further sequela. Quickly, just looking at some of the subgroup analyses for intention to treat. Most of these were underpowered because of the limited events in the apixaban group. But one thing that we did do was to distinguish between the provoking risk factors. We created a group of patients with the generally accepted major provoking factors of major surgery, major trauma, and prolonged immobility, and did not see effect modification compared with patients who had perhaps more minor provoking factors. Again, if we're looking at major and clinically relevant non-major bleeding in the safety analysis set, we did not notice any major deviations from the expected findings according to a number of different subgroups. I'm not going to go through all of them, but by and large, patients had similar outcomes across these subgroups. Overall, for death major bleeding and clinically relevant non-major bleeding, I would say that for the clinically relevant non-major bleeds, they were typically pretty minor. The requirement that we had for flagging a clinically relevant non-major bleed was contact with a clinician. Most of these patients didn't require a visit. You can see that, especially in the apixaban arm, a lot of these clinically relevant non-major bleeds were vaginal bleeding, rectal bleeding, or epistaxis. So putting this all in sort of the context of what we know from the literature, we've seen a number of studies really defining our practice for unprovoked venous thromboembolism in the setting of active cancer. And then it's been general practice to extend anticoagulation for patients with VTE and severe thrombophilia. Now we see this piece of the puzzle for provoked venous thromboembolism with enduring risk becoming a little bit clearer. HiPro highlights a population with provoked venous thromboembolism and enduring risk in which the risk of recurrence off of anticoagulation appears to be high enough to warrant at least consideration of continuing anticoagulation. The other important thing is, like many of the trials that have looked at extended duration anticoagulation, we also noted the hazard of clinically relevant non-major bleeding, and that highlights the importance of a bleeding risk assessment and shared decision-making with the patient about what concerns they have and what they place most emphasis on for their worries. For limitations, there are a number of limitations of the HiPro trial. First, it was a single center study, and that can eliminate or limit the ability to generalize the trial findings. We have a major thrombosis center of excellence with a lot of throughput of patients and are very comfortable with following our patients. Our electronic health record typically has a wide reach, and so most of our patients follow up with records that are readily available for monitoring. Other systems may not have that, and so such a strategy that we employed in HiPro may not be possible. The ability to discern differences in outcomes among various subgroups was limited by the sample size, and an important difference in clinically relevant non-major bleeding may have been missed since HiPro was not powered for the analysis of that endpoint. So in conclusion, compared with placebo, apixaban 2.5 milligrams orally twice daily reduced the risk of symptomatic recurrence over 12 months in patients with provoked venous thromboembolism and at least one enduring risk factor for recurrent events. The benefits of prevention of recurrent VTE were observed with a low risk of major bleeding, but we did, once again, like other studies, note clinically relevant non-major bleeding was numerically greater in patients receiving apixaban. Very quickly, just thanking my co-investigators, fellows, statistician, and all of the members that made this study possible. But mostly, we had incredible engagement from patients and their families that made it all possible. I would tell you that much of this study was actually born out of interactions that we had with patients in our pulmonary embolism support group, their questions, their concerns. And so this was really a trial that I think was influenced heavily by the patient voice. There was a wonderful editorial by Neil Zakai in accompanying the article, Art Within Evidence, Balancing Anticoagulant Duration in VTE Care. I thought we'd go through that and then go through some questions. I think one of the things pointed out by the editorialist was the high risk of recurrence in the placebo group at 1 year, and that was felt to be quite striking. I would say for us, it wasn't that striking because HiPro was really aimed at addressing a population that's been neglected in the literature, patients with provoked venous thromboembolism but enduring risk factors. We anticipated and really planned for a high risk of recurrence because we knew that we were enrolling patients with enduring risk factors that had a 2 or 3-fold multiplier for the risk of recurrence, and that many of these patients were going to have more than one enduring risk factor. Comment was also made that we did not use standardized definitions for provoking factors. There are really no truly standardized definitions for provoking factors. It's important to recognize that when you go to scientific congresses, when you read review articles and talk to experts, there's very little agreement on what things like long-haul travel entails, what is minor orthopedic trauma, and how bad does an infection have to be to cause venous thromboembolism. We're continuing to learn about these different risk factors, and every time I think we feel like we've got a good grasp on it, we find something new out. So I think it's very hard to use standardized definitions. HiPro was really pragmatic, and we didn't want to force definitions that may be debatable or become obsolete during the study on the enrolling clinician. Another comment was the high-risk nature of the population, with 1/5 of patients having a history of provoked venous thromboembolism. The guidelines haven't really been consistent on that point on what to do with patients with prior venous thromboembolism. If you try to look up what happens to a patient who's had a provoked venous thromboembolic event in the setting of hip fracture and then has a knee replacement and has another event, you can't really find strict guidance on what to do with these patients. Many patients in clinical practice have had recurrent provoked events, and many clinicians stop anticoagulation after these events. So also, if you look at many of the extended duration thromboprophylaxis trials like Amplify Extension, Einstein Choice, and Remedy and Resonate, they all included populations where almost about 1/5 of patients had a history of provoked venous thromboembolism, somewhere between 17 and 18%. Another excellent point was recruitment patterns matter. Many of these patients were enrolled by 2 clinicians at our center, me and one of my colleagues. Like I said, this represents our clinical practice. This was a common referral to vascular medicine at our hospital and to our colleagues in hematology and pulmonology. And so we really wanted to try and understand how we could answer this question rather than continuing to make it up as we went along. And so we did this as an investigator-initiated study. And we're happy to try and answer this question. Regarding sort of patients that may have had different types of provoking factors, like I showed you in the analysis that we did for the subgroups, we created a group that had basically the well-defined major provoking factors of surgery, trauma, and prolonged immobility, and compared those with more minor provoking factors and really did not see effect modification. Thinking about this more in the context of what we do in clinical practice, I think incorporating the HiPro trial into our care of patients with venous thromboembolism, we need to remember that bleeding has to be part of our risk assessment. It's not enough to simply look at risk of venous thromboembolism recurrence. We need to take into account the risk of bleeding. There are lots of different ways of doing that. VTE bleeds a score that I find helpful, but there's also VTE predict. And even the HAS-BLED score has been used in VTE patients. So I think it's important in shared decision-making to make sure that bleeding's discussed. This was a study that I really liked, now about 2 years old. that looked at indefinite duration anticoagulation in a Canadian cost effectiveness analysis, essentially looking at 1,000 patients with first unprovoked venous thromboembolism, looking at indefinite versus time-limited anticoagulation. And with indefinite anticoagulation, you do reduce the risk of recurrent venous thromboembolism. You also prevent pulmonary embolism, but you cause bleeds, including intracranial hemorrhage and fatal bleeds, and it's quite costly. There's an increased cost to indefinite duration anticoagulation, and patients also have a decrease in quality of life ever so slightly. So I think we have to take into account a lot of different patient preferences. There are concerns about VT recurrence, there are concerns about bleeding and implications on cost and lifestyle, especially for our patients that either have hobbies or occupations that put them at risk for bleeding. There's a lot of heterogeneity in the guidelines right now, and we're hopeful that with newer guidelines taking into account the many studies that have come out, including HiPro, that this will become a little clearer. So now I want to go on to some awesome questions that were submitted ahead of this presentation. I want to start with this one. The inclusion criterion of provoked DVT and/or PE does not appear to be clearly defined. I would say that in the spirit of a pragmatic trial, the study executive committee recognized two key observations that limited a more specific definition of provoked. First, that there aren't really widely agreed upon definitions for which factors qualify for provoking factors. Case in point, I have some colleagues that are much more expert than I in venous thromboembolism who argue about whether hormonal contraception is really a provoking factor. So many women go on hormonal therapy and don't have VTE. Some of my colleagues actually would treat this as an unprovoked event, and then others feel that it is a strong provoking factor. It was also impractical to think that a list of provoking factors could be comprehensive and up to date. And a great example of this is when we conceived of HiPro, we had neither heard of COVID-19 nor had any experience with JAK inhibitors as risk factors for venous thromboembolism. And by the time we started doing HiPro, both had become risk factors that were recognized as contributors. So these lists, we were very cognizant and concerned about creating a list that would become obsolete in the middle of the study. And as such, that was something that we carefully considered. As stated in the protocol, for what it's worth, every single case was reviewed by the study investigators before enrollment to ensure that there was a provoking factor and that criterion was met before the patient was enrolled. Another question, what were enduring risk factors such as how were enduring risk factors such as heart failure, chronic lung disease, and atherosclerotic disease defined? Enduring risk factor categories were defined in the study protocol, and specific risk factors within each category were specified in our case report form to aid the staff in data collection. So to provide definitions, heart failure was defined as a problem list entry, medical history, or visit diagnosis of heart failure with reduced ejection fraction, mildly reduced ejection fraction, or preserved ejection fraction. And this was based on EHR studies that have shown that the positive predictive value of these diagnoses for heart failure exceeds 90%. Chronic lung disease was defined as a problem list entry, medical history, or visit diagnosis of restrictive lung disease or obstructive lung disease, with EHR documentation being shown to have a positive predictive value in excess of 99%. Atherosclerotic cardiovascular disease required objective evidence of atherosclerosis on imaging, either CT, fluoroscopy, or ultrasound, and had to be confirmed by investigator review. It wasn't enough to just see that in the medical record. Another excellent question. What was the risk of VTE recurrence of patients screened but not enrolled into the trial, specifically the patients who had provoked VTE but none of the persistent provoking risk factors? As this was not the aim of the study, such data were not collected. And while it's a great question, we have to remember that patients who were screened but ineligible did not sign an informed consent form. And as such, our IRB would not allow us to approach these patients to collect data regarding VTE recurrence. Furthermore, an EHR review may miss important recurrent events that presented at non-affiliated sites and would result in an inaccurate estimate. So we really would have had to have consented all of these patients that were screened but didn't ultimately enroll in order to accurately get their VTE recurrence rate. And that was not logistically feasible, especially considering the study was executed in the middle of the pandemic. How were hormone-associated VTE patients classified? Hormonal therapy as a provoking factor was defined as estrogen-containing contraception, estrogen-containing hormone replacement therapy exclusive of vaginal estrogen, selective estrogen receptor modulators, or testosterone supplementation. I would just note that no patients enrolled had VTE in the setting of SERMs or testosterone supplementation. Other hormonal therapies such as aromatase inhibitors and progestin-based contraceptives did not qualify due to the absence of consistent data supporting VTE risk. Another excellent question, when was the study performed and what was the catchment enrollment area? So as documented in the published manuscript, the study was performed from November 2020 to November of 2023. Patients were screened and enrolled through our vascular medicine clinic at Brigham and Women's Hospital. During the study period, Brigham and Women's Vascular Medicine had 8 full-time faculty, each with at least 1 weekly longitudinal clinic, and 3 full-time advanced fellows, each with weekly longitudinal clinics. And this was a very common referral, and so we saw many patients for this. We were in the IRB process required to document a priori that we had enough patients referred with provoked venous thromboembolism to meet our enrollment goals. And so before we could be approved, we had to do an EHR-based query, which we did from spring of 2020, which we did in the spring of 2020, surveying 2017, 2018, and 2019, and estimated that the Brigham and Women's Hospital Vascular Medicine section saw an average of 1,500 outpatients per year referred specifically for provoked venous thromboembolism. Hopefully that allays any fears that we didn't have enough patients to do this. Role of aspirin causing bleeding in the apixaban 2.5 milligram twice daily group. In the supplementary appendix, which is available accompanying the manuscript, we addressed this exact point, which is excellent, in our subgroup analysis, where we showed really no effect modification for patients who continued low-dose aspirin. Great question. Did we collect D-dimers? Unfortunately, this was an investigator-initiated study with limited funds that we had to dedicate to the design, execution, and completion of the primary trial. And so we had to give up some of the other ancillary analyses and things that we thought would be interesting and helpful, including biomarker assessments. Had this been a sponsored trial or something of the like, then perhaps we would have been able to do that, but unfortunately could not. You grouped patients with various provoking VTE risk factors together. However, previously you had argued that one should stop dichotomizing VTE into provoked and unprovoked. Would you please take reference of this discrepancy? So appreciate pointing out this discrepancy. I think if you look carefully at this, you can understand that it's not quite the discrepancy that it appears. The article that my colleagues and I wrote back in 2018, Let's Stop Dichotomizing VTE as Provoked or Unprovoked, was primarily aimed at avoiding the use of that dichotomy in determining risk of recurrence and duration of anticoagulation. Terminology such as provoked and unprovoked still permeates the guidelines. If you actually look at the guidelines, they still use those terms because it's worked into our lexicon as some risk factors being persistently there and other ones coming and going. Our trial closely followed the growing sentiment among experts that dichotomizing VTE into provoked and unprovoked is really not sufficient for determining optimal duration of anticoagulation. And we particular embrace the ISTH guidance that there are transient and persistent risk factors that have to be accounted for in sort of the assessment, and also the ESC guidance that when we categorize risk, we have to also remember that there are these different risk factors. Provoked and unprovoked, as I mentioned, are still commonly used in the guidelines, but they're used differently than they used to be used. They're not used to dichotomize patients into two groups. They're used to describe the different risk factors that patients have or the absence of such risk factors, which I think is important. I would say, if anything, the HiPro protocol that we followed advanced the call to stop dichotomizing VTE as provoked and unprovoked, because what we did first and foremost was put enduring risk factors at the center of what we did in the trial. We enrolled patients with VTE in the setting of some kind of a trigger or provoking factor, but they had to have an enduring risk factor as well. And this is one of the first studies to, I think, really make that stark departure from just recognizing the provoking factors in the short term or the absence of them. And here we can see the ESC guidelines, which include recognition that some are transient factors and some are enduring factors, and they all need to be accounted for. We can see here in the ISTH guidelines, they still use the words provoking because that's really part of what clinicians understand when they evaluate patients who have VTE in the setting of some certain circumstances. And with that, I would like to thank everyone for their attention, the amazing questions that I got ahead of time, and the opportunity to be able to address them.
Thank you so much, Greg. Wow, what a great presentation and thoughtful questions addressing kind of what some of us may be thinking in the background. You know, one of my primary roles in my day job is evaluating duration decisions and risk-benefit analyses at the end of the treatment course. And you know, to your point, you know, provoked and unprovoked is just so it's unacceptable, because what I find so much is that there is this wide gradient of gray where patients live. The other thing that it does is it makes us focus an awful lot on, you know, the provoking event, and assume that we're starting that all patients have some baseline equal level of VTE at their core, and that's simply not true. And so the other thing that this really kind of, it makes us stop thinking so much about the provoking factor and ongoing risk factors. The way that I often explain it to patients is, you've proven now that when pressed, you will have a VTE event. And so trying to evaluate then and say, you know, does the, you know, is the juice worth the squeeze to keep you on anticoagulants long-term at that point? So thank you again for doing this extremely important trial. I was excited to be able to just, once it was published, to put this webinar on. I'd like to throw it over to our panelist, Margaret Fang. Margaret, you know, in your practice as a hospitalist and in your work as within thrombosis, what does this do for you? What is this, how does this change your thinking or change your practice?
Well, first of all, it's such an honor to be on this webinar with Dr. Piazza and get a peek under the hood of this trial. So really, really amazing. And I would say that my approach really reflects what you, Arthur, and what Greg said, which is, I think the first one is the old idea that we had, that if you were in a provoke, you had a major surgery, you had a VTE, that you can get away with just 3 months because everyone was at a low risk, is now should be much more nuanced, that ultimately VTE may be a chronic condition, or you may have a chronic elevated baseline risk, and we need better ways of estimating and identifying what that person's risk is. So I think a lot about it like in atrial fibrillation, where you have risk scores to estimate someone's risk of stroke and then help us determine whether the risks of anticoagulation is beneficial. I think a similar paradigm should be applied for VTE, and I think this was a great study to demonstrate that. So aside from individualizing your baseline risk of VTE, I think the other main take home is that anticoagulants work. And when, I mean, it is, it's like study after study in different thrombotic conditions. If you give someone an anticoagulant, it works to prevent thrombosis. So what Greg said about it has to then, well, what's the consequence of it? I was very interested by the Markov decision analysis because I think you could take the HiPro study and say, well, okay, basically that applies to almost everybody that we're seeing in the hospital. You know, anyone with atherosclerotic disease, with obesity, with chronic kidney disease. I mean, does everybody benefit from being on an anticoagulant or a low dose? And I think the Con study, which really focused on therapeutic anticoagulation, said you're never going to get cost effectiveness. You may not even get an improvement in quality adjusted life years if your bleeding risk is at all elevated. Now, I think what will be really interesting is if you redo the Con study using the much lower rates of bleeding that you see with the low dose anticoagulants. And so that's the third one, that anticoagulants work for VTE. The trade-off between major bleeding and VTE is quite different from stroke and bleeding and AFib. But now you have this new thing, and now there's study after study that low dose DOACs may have, or maybe non-inferior to full dose DOACs for prevention, secondary prevention of VT. So I think that may actually shift our approach. So how does this work? I mean, ultimately, I think this is the shared decision-making. You try to estimate someone's baseline VTE risk. Amazing, Greg, that your clinic was able to find those people who had that elevated risk and not the really low risk that we used to think about with the major transient, and demonstrate that you could prevent it at 1 year. Now, the question is, these were what, 50, 60-year-olds? Are you going to keep someone on anticoagulant for the next 30, 40 years? And I think that's a bigger question in my mind.
Yeah, excellent feedback. You know, the term that is jumping into my head, there's so many things in medicine where we talk about a spectrum, a disease spectrum. And I think that it would behoove our audience to get out of this dichotomy of, you know, provoked, unprovoked, and really think about VTE risk as a spectrum that's extremely individualized to the patient, not only based on why the clot happened in the first place, but what's going on with them currently, what may be going on with them in the future. There's so much variation, and unfortunately, we don't have a magic 8 ball to look at and tell this patient what their annualized risk of a VTE is. It's just simply, there's just too many variables to control for that. You know, Greg, I might take a quick second. One of the populations that in the study that kind of made me question my own practice is you incorporated patients who had calf-vein DVTs. And my stance has been, and I've lectured on this, so please correct me so I can go undo all of the evil I've done. But my stance has kind of been that there isn't, the way that I read the guidelines, there isn't actually a precedent to consider long-term therapy when folks present with certainly superficial vein thrombosis, isolated distal DVT, for which there's some degree of equipoise in acute treatment, upper extremity DVT. It's, at least the guidelines are silent on it. They don't really consider long-term therapy. So can you speak to kind of the practice of Brigham and Women's when it comes to those particular types of VTE and consideration for duration?
Yeah, Arthur, it's a great question. So I think you know, you hit it right on the head. There are different types of venous thromboembolism. I would quickly say that, you know, superficial vein thrombosis is not one that typically, you know, if we do anticoagulate, it's certainly not done for any long period of time. For distal DVT, it's really interesting. There are two observations on that. One is that when we were planning the study and I looked at what our faculty do, it was all over the map. Some faculty would follow the guidelines that said, even if it were unprovoked, they don't recommend long-term anticoagulation, and so it would be treated for short-term. Others actually would still, if it were unprovoked, continue anticoagulation long-term. And some of the patients that ended up joining Hi-Pro did so to see if they could get off of anticoagulation. I think that the other thing is there was a wonderful study by Rob McBain that was published in Thrombosis and Hemostasis a few years ago, done through Mayo, that demonstrated there is a difference in the types of calf veins. They're not all created equal. Calf veins that are muscular, that are the gastrocnemius and soleal veins, have a much lower rate of both pulmonary embolism and VTE recurrence when compared with axial calf veins that include the PT and perineals. There seems to be enough of a recurrence rate to support longer term anticoagulation, or at least a risk there for recurrence. So I think part of the data that comprised what we've done for distal DVT has been based on an important fallacy that they're all these calf veins are the same.
Yeah, it makes a lot of sense. I was unfamiliar with that work. Thank you. But certainly, if you think about the anatomy, the tibialis, for example, has a direct path to the popliteal, which has a direct path to the femoral, and so on. So makes a lot of sense.
Yeah.
Naomi, let's bring you in here. I know we had some submitted questions, folks. I apologize ahead of time if we can't get to all of the questions. We had some categories pre-submitted we wanted to make sure we covered. So Naomi, take it away.
Yeah, thank you, Dr. Piazza. Excellent presentation. There is one at the top of the list here that I know that everybody is dying to hear about. So many guidelines, of course, consider 3 months as the end of your acute treatment phase of therapy following an acute VTE. The rivaroxaban and apixaban suggests consideration, the labeling suggests consideration of step-down dosing after at least 6 months of standard therapy. Hi-Pro, we see now, for you guys, you use 3 months. So does Hi-Pro now set a precedent for us to look at the duration and intensity decisions at the 3-month mark rather than at the 6-month mark?
That's a great question. Hi-Pro's just one trial, and I think it really depends on what further data will show. If you looked at the average time between or the average duration of anticoagulation within Hi-Pro, it was actually, because patients didn't necessarily enter the study after 3 months. Some of them had been on anticoagulation for longer. The average was 6 months.
Okay, gotcha. Thank you.
Read the fine print.
Yes.
Naomi, what else did you have in those categories?
Yeah, so we've got another one here that's asking about the role of repeat imaging. This keeps coming up. People want to know, should we repeat image or no? If you have that clinical equipoise, somebody who, well, they have these enduring risk factors, we're not sure what to do here. Could you repeat image to see if that clot is still present?
Yeah, it's a great question. Really nothing to do with Hi-Pro, but more of a great clinical practice question. I tend to do repeat imaging for DVT because my experience is that a lot of these patients will subsequently come in with edema. And if we don't document what is left as a baseline after treatment, typically what'll happen is they'll come in, they'll get an ultrasound. Really chronic DVT will be seen, but the ultrasound reader will say something like can't exclude acute or some other qualifier. And then either the patient will be restarted on anticoagulation for an acute event, which will now be labeled chronic, not chronic, recurrent, or if they're on anticoagulation, this is a failure and they'll switch to, this is how patients end up on like lifelong fondaparinux because, somebody
failed therapy.
Yeah. So we have to really, I find it just invaluable to have that completion ultrasound so that I can look at the ultrasound and say, look, this was all documented before. It's never gone away. And that's important. There's this old adage that you can't age thrombus on an ultrasound. it's part true and part false. If you have a baseline ultrasound to compare it to, then you're in much better foundation to age the thrombus.
Right. Let me just jump in on that, because I think where people end up getting this wrong, specifically patients and say, primary care providers, those that don't operate in thrombosis, is what is the goal of that repeat ultrasound?
Yeah.
And the goal, and what tends to make common sense is, hey, I had a blood clot, I treated it, the blood clot should have gone away. That's the goal of therapy. And that is actually not the goal of therapy. Up to half of the time, the clot never clears. And so repeat ultrasounds, as long as we go in understanding what the goal is, it is not to drive therapy decisions. It is to determine a new baseline, as Greg mentioned. It is to have something to compare to, because I can't tell you how many calls I've had just like the one that Greg just described, and not having that ultrasound. So where I have incorporated it a little bit more is when we are stopping therapy. But it certainly makes sense to do it in others. And by the way, there's a European guideline, ESV, or there's a I think 2021, a European guideline that does incorporate the concept of adding a repeat ultrasound when therapy is being stopped. So it's just important to understand the goal of that therapy. Now, there is something to be said about, and this gets very nuanced, the risk of how does venous stasis or how does chronic thrombus play into the role of recurrence risk, that kind of thing. And also keep in mind what Greg said, that when you have post-thrombotic syndrome and those kind of things, those symptoms can look a lot like an acute DVT. So just having an ultrasound that says his legs swelled up and he has a clot, there's only so much you can do with that information.
Exactly. But what you said, Arthur, was really important, that, you get these patients at 3 months, they get an ultrasound, because they ask for one, or the clinician does one, and it's still there. And the clinician says, "Oh, wow, I didn't expect that to still be there. Let's keep you on anticoagulation. We'll check back in another 6 months." And then that comes up and it's still there. And so they're like, can't believe it's still there. Let's go for another year. And that's how patients, again, end up in long-term anticoagulation, not necessarily for cause, unfortunately.
Right. Yeah. So excellent points. Naomi, did you have maybe one more? There's also, I was thinking we could do rapid fire of the questions that have come through here on the Q&A, but do you have maybe one more pre-submitted?
Yeah, so you guys talked about the isolated distal DVT, superficial venous thrombosis. There was one question about recurrent, strongly provoked VTE, so like major orthopedic surgery despite adequate prophylaxis without ongoing risk factors. So kind of a niche scenario here.
Yeah. So I think that falls back into what I was mentioning, like, where is there precedent? Where has there historically been precedent to consider long-term therapy, and where has there not? We already spoke about SVT, about isolated distal DVT, but what about provoked, recurrent, strongly provoked? So let's say these are actually really strongly provoked and they don't fall in that really gray area. So if you have recurrent provoked events, is there precedent to consider long-term therapy?
Yeah, I mean, we had those patients in high pro, so certainly that would be a reasonable follow-up study to focus on that population specifically. But again, if there's persistent or enduring risk, that becomes the factor. Someone who didn't have any enduring risk factors at all, they didn't make it into high pro.
So they would have. So if it were recurrent provoked in the absence of the identification of an ongoing risk factor,
We didn't study that population.
You didn't study that population. Thank you. Okay. Let's
Greg,
see what we have here.
I have a question.
Yeah, please, Margaret, go ahead. Thank you.
High pro looked at patients up to 1 year. And so, clearly you could reduce the risk of recurrent VTE. And we know that VTE risk, it goes up, it continues to go up over time. It just plateaus a bit. How long are you keeping your patients on low dose anticoagulation? Are you now changing your practice and saying, for people with enduring risk factors, you're going to be on lifelong low dose DOACs?
Yeah, so what I'm doing in my practice is it's essentially still shared decision making, but now we add the information for high pro, recognizing that also for Amplify Extension, for Remedy and Resonate, for Einstein Choice, also they looked at, those studies aren't ongoing. They didn't continue to follow patients for years. And so we extrapolate that if 1 year is good, then
4 years or better.
what I do is the patient comes back every year and we assess bleeding and we assess how they're doing on their enduring risk factors. Some patients that may have enduring risk factors that have been remedied. The classic example might be someone who had an inflammatory disease that now is in remission and strongly so with no evidence of disease activity. We talk about that as well in shared decision making.
My follow-up question is, so aspirin versus placebo. Aspirin has a weak but protective effect in VTE. And at the same time, we're now also very wary of combination therapy, combining anticoagulants and antiplatelets. So 20% of your patients in HiPro were also on low-dose aspirin. What do you do with their aspirin now that, let's say you're going to keep them on low-dose DOACs?
If at ESC it was open season on aspirin in August, basically the number of studies finding fault with aspirin in a number of different settings, including like after PCI, were too numerous to count. My conversation is now like spending time on how we can get patients off of aspirin.
Excellent. Yeah, I think that's a very good effort. I think that the most bang for your buck is probably aspirin and NSAID avoidance if we want to talk about actual safety of anticoagulants. Completely agree with that. I'm going to go rapid fire on a couple of these. I might hit answers, and if I get them wrong, slap me around. But there's a couple of questions about gosh, what do you do with laminated DVT? Doesn't matter where it is. The answer is goes back to what we said earlier. It's not about the clot they had. It's about the risk of a future clot. So if you have imaging that shows chronic thrombus, while there's some suggestion that residual vein thrombosis might drive a little bit of VTE risk, it's still not about that clot. It's about the risk of future clots.
And to hammer that point home, because that's a really important, maybe the most important point. There are patients, especially young patients, who will have a DVT. They get put on anticoagulation. For some reason, they have some calf pain. They get another ultrasound, and 2 weeks later, it's gone. That doesn't mean you can stop anticoagulation, and that's the danger of not knowing why you're doing the ultrasound. Exactly.
Yeah, excellent point. Not only is it not about treating the clot until it's gone, it's not about stopping the anticoagulant if the clot goes away. It's that patient developed that clot for a reason, and it takes time for whatever caused that to go away with the inflammatory process. Similarly, there was a question about what about repeat VQ scans in general. So we wouldn't do repeat CT scans for PE evaluation to see if it went away, because we don't expose patients to radiation for that. VQ, I suspect only if there's suspicion of CTEPH, which is more of a pulmonology issue or a cardiology issue. Would you agree with that?
Yeah. I mean, there are reasons to do repeat imaging for that, but typically we don't just do it on especially CTs with the concern of radiation. We want to be careful about that.
Okay, thank you. All right, Naomi, do you have maybe one more that came through the Q&A by any chance you want to mention, and then
Yes.
Yeah.
Yeah, so this is related to the amount of risk based on the patient's enduring factors. So this question is saying that you included patients who were provoked by trauma and surgery. These patients have been shown to only have a 1% risk of recurrence per year. Were you looking at the effect of ongoing risk factors in these patients who have been viewed in the past as very low risk for recurrence?
Yeah, so it's a great question, but it's really asking two different things, or it's addressing two different populations. The general population that has trauma and a certain amount of VTE risk is not the same as the enriched population that we had in HiPro. We were specifically interested in patients that had a constellation of enduring risk factors that modify the risk substantially. That's why it's one of the I think the editorialist also raised the point of the rate being higher than we would have expected for patients with provoked venous thromboembolism. Yeah, it's higher than we would expect for a general all-comers population of venous thromboembolism, but it's right where we would expect for patients who had persistent risk factors.
Right, thank you.
Excellent. Well, thank you again. What a great discussion. I'm glad we had time for some discussion around this very important trial. And I just wanted to point out and say, you know, Greg's been a busy guy. High Pro is a super important study, but I also wanted to point out a couple of quick publications that we came across here recently published. First, he did a beautiful review on superficial vein thrombosis. He led that paper and JAMA review. Beautiful. Much needed study. One of the things that I've preached and that I've lectured on is not all clots are the same. And the fact that we in this space can understand that and can navigate that is what makes us quite valuable. He also did this paper or was involved in this paper, delayed venous thrombosis diagnosis and mortality risk. This has been an interesting topic of late of what happens when a patient shows up, has some symptoms, doesn't get picked up on, and it there's a delay in the actual diagnosis of the VTE. Super important topic. Are there any other slides? Don't think there are. We are right at the top of the hour. Thank you guys for joining this. Beautiful topic. Thanks again to my co-moderator, Naomi, to our panelist, Margaret Fang, and especially to Greg Piazza, put a lot of work into this. And thank you so much for this study. We'll see you guys next time. Thanks.
Everybody.